you do cleaning of the site with betadine or hygiene. You have to confirm the needle position both at longitudinal and transverse views. And make sure after the procedure you do rescanning to make sure there is no hematoma or complication after the procedure. For local anesthesia, you could use lidocaine or bupivacaine. Lidocaine is a fast-acting anesthetic with a short duration. Bupivacaine more slow-acting with a longer duration. Make sure you know some facts about local anesthetics. There are some contraindications for lidocaine, including heart problems such as heart block, bradycardia pacemaker, or prior use of amiodarone. There are some adverse effects of lidocaine, although very rare. There may be some severe allergic reactions, especially at high doses, and it may have effects for the central nervous system or cardiovascular effects, tinnitus, tremor, or hypertension. Really, some people may react with a lidocaine shock, so you should do careful history taking of the patient, and if the patient shows any signs of hypertension and perhaps impending shock, you should take the necessary precautions. Some contraindications for bupivacaine for intravenous use, and be aware that bupivacaine has cardiotoxic effects and rare allergic reactions at high doses with central nervous system and cardiovascular effects. Some facts for steroids. The most common steroids used are triamcinolone and methylprednisolone, which is otherwise called Depo-Medrol. Some different characteristics, but these two are the most commonly used steroids. Move back the slides. Why don't we have the previous slide mover up here? Okay, so you prepare the site and insert the anesthetic into the site that you want to do the procedure. You insert the needle about 1 centimeter into the soft tissue and find the needle by moving the transducer. You advance the needle under visualization. Try and inject small amounts of anesthetic or air to confirm the needle tip. Then you orient the needle perpendicular to the ultrasound exam. Do not move the needle unless it's completely seen longitudinally all the way down to the tip. And always try to trace the whole length of the needle. Do not move the transducer and needle at the same time, as this moves the needle out of sight, out of view. So make sure you visualize the needle throughout the whole procedure. For the needle path, try to secure the shortest distance. Also, you have to avoid hitting neurovascular structures. You can confirm the presence of vascular structures by using Doppler exam if necessary. For superficial masses, the puncture site should be apart from the probe position. Needles on ultrasound are seen as echogenic linear structures with a strong ring-down artifact, and I will show you what that means. They are most echogenic when perpendicular to the transducer. So you could move and angle the needle, or you could move and angle the transducer, but don't move both needle and transducer at the same time. This will not help you target the lesion. Okay, so like I said, you either move the needle if it's not completely visualized, or you move the transducer and try to orient the needle and the transducer at 90 degrees, so perpendicularly. Do not move the needle and the transducer at the same time, like I said before. Like I said, it's best to have some distance between the probe and the needle, so that both the needle and the transducer will be aligned at 90 degrees. This allows you best visualization of the needle. This is the ring down artifact. You can see these echogenic acoustic shadowing or enhancement, sort of. It looks like you have multiple needles posterior to the needle. This is called ring down artifact, and it's more prominent when the probe is more perpendicular. It's more echogenic, and you can see more ring down artifacts. This just means that the needle and transducer are aligned properly. Okay, for ultrasound guided biopsy, these are the indications. You do ultrasound guided biopsy to establish a malignant or benign diagnosis of a soft tissue tumor. For bone tumors, if the cortex is intact, you can't really do ultrasound guided biopsy too well. But for some bone tumors with cortex destruction, you may try to do ultrasound guided biopsy. Otherwise, it's better to do CT guided biopsy for bone tumors. You also can do ultrasound guided biopsy to obtain material for culture or other lab studies. Some contraindications. Sometimes the clinician thinks it's a soft tissue mass when it's in fact an aneurysm, avifistular or vascular structure, and we can easily identify these by using Doppler exam. You should try to avoid nerves, and if there is a severe coagulopathy or bleeding tendency, it may be dangerous to do biopsy because it can cause a hematoma and bleeding. If the patient is not able to cooperate, it may be difficult. It's not an absolute but relative contraindications for biopsy. There may be some complications, bleeding, higher incidence with larger bore needles, infection, very rarely. Usually it's no problem if you use aseptic procedure and if the patient is not immune compromised, but it has higher incidence if the patient is immune compromised or the site is not aseptic. It may cause unintended organ injury. Not too common with ultrasound guided procedures done properly by an experienced radiologist. There may be tumor seeding of the needle track if you don't follow the proper guideline. A biopsy gun, there are many kinds of biopsy guns. I usually prefer the automatic kind of coaxial spring-loaded automatic guns. There are throw lengths of 1 or 2 centimeters. You choose 1 centimeter for smaller lesions, 2 centimeters for larger lesions. As you can see in this picture, there is a core. When you shoot out the core, you see this notch, the throw length of 1 or 2 centimeters for the specimen. And then when you shoot the gun again, the sheath comes out and cuts into the tissue. So for soft tissue mass, you can do ultrasound-guided core biopsies, usually using 18 gauge gun biopsy, sometimes 16 gauge. So, ultrasound-guided biopsy is very good for superficial masses. You can easily do this. Prior to biopsy, you should evaluate and target the solid portion for biopsy. For the cystic portion, it's better to aspirate. And you can also do cytology or culture from the cystic portions. Diagnostic yield is usually over 75%. Better for bigger lesions. Biopsy needle size, you can use anything from 14 to 18 gauge. If the patient has a bleeding tendency, it's better to use thinner gauge size. And like I told you before, for guidance, if it's a soft tissue, superficial soft tissue lesion, it's better to use ultrasound guidance. If you have an intraosseous lesion, then you may want to use CT guided biopsy. You should obtain specimen at least 4 to 5 times or more if you can. The more specimen you get and give the pathologist, the better the chances of accurate diagnosis. So I usually try to obtain at least 5 tissue fragments when I do biopsy. Like I said before, you should try to avoid neurovascular structures by using Doppler ultrasound. It's helpful oftentimes to discuss with the surgeon about the appropriate puncture site. So you should include the biopsy site after discussing with the surgeon. Try to biopsy along the surgical incision site. This is to avoid needle track seeding, so the biopsy site should be along the surgical incision, usually along the longitudinal axis of a muscle and not crossing transversely, as this may cause contamination and tumor track seeding. You shoot first, and this forwards the core, and then shoot secondly to get the sheath cutting into the specimen. But if you have very small superficial lesions, you may want to put forward the core first and then insert into the mass, then just shoot the sheath. I don't know if this is understandable to you. I think unless you have had experience with biopsy, this may be hard to understand. Be careful not to pass the mass, as this may cause contamination of the deeper structures or hit deeper vital structures. So this is how a ultrasound-guided biopsy would look like on ultrasound. So you shoot the core first and then cut into the specimen by shooting the sheath. But if you have something very superficial or small, you may want to just put in the needle with the core already shot forward and then cut with the sheath. For cyst aspiration, we have different indications. You can aspirate a ganglion cyst, a paralabral cyst for shoulder and hip, cuff cysts, complicated fluid collections, which is one of the most common indications for ultrasound-guided cyst aspiration. The fluid collection may be hematoma or abscess, or you may not know and try to determine whether it's a hematoma or abscess. For very viscous, thick fluid, you may want to use a large bore needle, such as an 18 gauge needle. Okay. And also, if you have a cystic neoplasm, where you want to aspirate the cystic portion and do cytology. And sometimes, if necessary, steroid may be injected after aspiration of the cyst. This is an example of a paralabral cyst. often accompanying, but not always, superior labral tears, such as lap lesions. The cyst may extend from the suprascapular notch
Chị nhấn siêu Việt Nam là ra như vậy.
Và cái kia.
Chị vào Google ấy.
to the sphenoglenoid notch. You can use a posterior approach along
Siêu
the
Việt Nam
axial
là ra. Chị gõ
plane.
siêu Việt Nam là ra.
Inject the
Chị đăng ký
needle
một cái tài
from
khoản.
lateral to the medial side. This is a Mauro Lavallee lesion. Mauro Lavallee lesion, as you may well know, it's sort of a chronic hematoma after trauma due to fascial injury. So you may want to aspirate after ultrasound guided injection of the needle. And now the hematoma is decreased, but oftentimes Mauro Lavallee lesions recur, so you may want to follow up with ultrasound. Rotator cuff cyst can be aspirated under ultrasound guidance, as in this case where you have a large rotator cuff cyst within the supraspinatus tendon, the supraspinatus muscle actually, and you can see readily that that cyst is located within the muscle. You can see, you can usually do a lateral to medial approach. Complicated fluid collections, especially around prosthesis. On MRI, you have this susceptibility artifacts, which actually prevents proper evaluation of the complicated fluid collection, but on ultrasound, the fluid collection is seen readily, and also aspiration can be done readily. This is a case of hip infection. At the left side, it was a post-op infection, so you see these antibiotic beads, and the clinician suspected infected fluid collection, which can't be seen on the radiography. When you do ultrasound, you can see that there's something going on at post-op site at the hip joint. See hypoechoic fluid collection, but because it's the hip joint, it's very deep, so you can't really see everything with a linear transducer. It's better to use a convex transducer, and you can do intervention, as you can see the needle here. Joint aspiration and injections can be done in cases where you suspect septic arthritis, to differentiate between septic arthritis and transient synovitis. For MR or CT arthrography, you can use ultrasound for contrast injection. And for arthritis and frozen shoulder, you can inject steroids. The mixture I usually use is 2% cc of lidocaine, 5 cc of normal saline, and 1 cc of triamcinolone. Pain management with ultrasound guidance is becoming more popular in Korea. I don't know how it is in Vietnam. You can do injections for tendinitis, tenosynovitis, adhesive capsulitis, Morton's neuromas, and trigger finger syndrome. You can use small bore size needles, especially for small structures. Aspiration and injection can be done for symptomatic ganglions, tendinitis, and arthritis, as well as bursitis. So for the shoulder joint, you can use the posterior approach, lateral to medially along the axial plane. For the superior joint space, you should use the coronal plane approach. And for rotator intervals, you can use sagittal or oblique coronal plane approach. It's necessary to know the normal anatomy, of course, to do proper ultrasound-guided interventions. So for the posterior approach, you approach the joint from lateral to medial side, as in this one, with the needle here. You can hit between the glenohumeral joint, glenoid side and the humerus. You can hit the glenohumeral joint, as you can see here, and aspirate or inject as necessary. You can also try to, if you can't really see the needle tip in the joint too well, you could use this approach where you try to just hit the humerus head, target the humerus head, and after checking the position of the needle, you can test inject to see that the joint distends, and then inject. For the elbow joint, you have the elbow flexed, use the axial plane approach, which would look like this on the sagittal MR image. Sorry. And you can see the needle tip here. For the wrist joint, you usually use a dorsal approach and try to target the joint from distal to proximal or caudal to cranial direction. You can target the radiocarpal or midcarpal joints. For the hip joint, you try to target the anterior recess, longitudinal to the femoral neck, from distal to proximal or caudal to cranial approach. And you can check whether the joint anterior recess gets distended by doing a test injection. For the knee joint, you have the patient usually lying down, supine, or in myoflexion. You use the anterior approach, targeting the suprapatellar recess superior to the patella, about 3 centimeters superior. You can either use medial or lateral approach. For the ankle joint, you usually target the anterior recess, either in the longitudinal or axial plane. For the sternoclavicular joint, as you can see in this case, you can usually use the axial approach from the lateral to the medial side. For the foot joint, this is the first MTP joint with inflammation. You can target from the dorsal aspect. You can see the ring donor effect here. For Berzal aspirations or injections, usually use 22 gauge spinal needles and target the subacromial subdeltoid bursa. And please try to avoid the rotator cuff to avoid injury. You can just target the bursa. Sorry. And aspirate and inject if necessary. For subacromial injections, you can use the approach going from the lateral to the medial, targeting the subacromial space. For Dickerbang's tenosynovitis, as you all well know, is inflammation of the first extensor compartment of the wrist containing the abductor pollicis longus and extensor pollicis brevis tendons. There may be inflammation, and you can inject around the tendons. Make sure not to inject into the tendon, as this may cause tendon damage and tendon rupture in severe cases. Aspiration lavage for calcific tendinitis, another very common procedure done in everyday practice in Korea. Can do percutaneous lavage and aspiration. Usually amorphous calcifications yield the best results. Sometimes you have the patient sitting, but I have, in my early days, I used to do this with patients sitting, and I've had patients sync up on me. So especially young men, I've had young men like fall down when I try to do this procedure, even before I put the needle in. So after that, I always have the patients lying down in a recumbent lateral decubitus position. Use the coronal plane for the supraspinatus tendon. Usually use a 22 gauge spinal needle. I prepare 10 cc syringe mixtures, normal saline mixed with lidocaine. I inject and irrigate, then aspirate to dilute the calcification and aspirate the calcifications until the calcification decreases. And then at the end of the procedure, I inject steroids into the adjacent bursa. So this is an example. You can see on the radiograph that there's dense calcification in the supraspinatus tendon, which I try to target and aspirate as well, as much as possible. This case was a young man who came into the emergency room due to severe shoulder pain. On the ultrasound, you can see this dumbbell-shaped echogenic calcification within the subscapularis tendon. You can see this cloud-like amorphous calcification on the axial radiograph. You can do ultrasound-guided targeting of the calcification, lavage and aspirate. And now you can see the calcification is almost gone, and the patient was soon relieved of the pain. So at the end of the procedure, I usually inject the steroid mixture into the bursa, not into the tendon. So in summary, it's important to use aseptic technique for ultrasound-guided interventions, confirm the pathologic lesion and safe pathway on ultrasound. Also, always confirm the needle tip before any manipulation, both at longitudinal and transverse views. Again, I'd like to thank Lee Sum for giving us the opportunity